We're going to get started with our grand rounds for this week. I'm Dr. Griffiths. I'm one of the neonatologists here at Phoenix Children's, and it's my pleasure to introduce our speaker for today, Dr. Eric Hysinger. Eric comes to us from Cincinnati Children's, trained as a pulmonologist. He did his medical school, residency, and undergrad, actually all at Vanderbilt, and then went on to do his pulmonology fellowship at Children's Hospital of Philadelphia. And he currently is an associate professor of pediatric pulmonology at Cincinnati Children's. We actually brought him here today for kind of two reasons. One is that we're having a BPD conference today, and one of Eric's kind of special interests is bronchopulmonary dysplasia. But he also has a focus on aerodigestive disorders, bronchology, and chronic respiratory failure. He's also an active researcher with NIH grant funding and has won multiple research awards. So anyway, we are very excited to hear from Dr. Hysinger on cardiopulmonary outcomes of infants over their lifespan.
All right, good morning, and thank you guys so much for having me out. I really appreciate it. It's one of my first times to Phoenix and one of the only times I've had a chance to stay and enjoy it, and it's hot. I want to go back home and get some cool weather, but we'll enjoy the sun while we're here because it's dark and dreary in Cincinnati. Like Pam was mentioning, we're going to be talking about cardiopulmonary outcomes in BPD really throughout the lifespan. And one thing I want everyone to remember is BPD and premature lung disease and premature cardiopulmonary disease, it doesn't stop when they leave the NICU. It continues well beyond and frankly into the adult periods. With that in mind, we're going to go through a few things today. We're going to start with just looking at the definitions of BPD and how those have been evolving over time. Start discussing how we're using imaging as a biomarker and how we're trying to understand new insight into the disease process for both BPD and patients that are preterm without BPD. And then looking at what's happening for the heart and the lungs for these kids as they age from the NICU into toddler periods through childhood and adolescence, and then all the way into time of when they're being adults. And as we're going through, you're going to see this concept come up a lot. What is BPD? Now, with that, some necessary things is, well, first off, why do we care? Well, it's chronic lung disease of prematurity. It affects kids primarily less than 32 weeks, although there's some argument about you looking at 36-weekers, and certainly the younger you are, the more likely you are to have this particular problem. Somewhere between 10 and 15,000 kids annually are going to be diagnosed with BPD. It's super expensive. Billions of dollars are spent every single year on children with BPD. As we look at just the initial NICU stay, the average is going to be somewhere between $500,000 and $1 million. And some of your more severe kids, say your trach and vent players, they may have $2, $3, $4 million stays. Lots of money goes into this, and we have very few things that are specific to be able to support it. It's also a leading cause of death for kids under the age of 5. So high impact in terms of cost, high impact in terms of morbidity, high impact in terms of mortality. And as we think about why kids develop BPD or consequences of prematurity from a heart and lung standpoint, I want to first go back to embryology. Yes, for residents, it comes back. I'm sorry, but you can't get away from it in pediatrics. And we're going to just look at the airway first. So the airway is going to come off the ventral foregut. It's going to start by about 4 weeks, and it should completely separate by the end of the 4th week of gestation, maybe early in the 5th weeks of gestation. And then you're going to see a very large explosion in the number of airways that you're going to get. You're going to develop all of your conducting airways. And this is going to be complete somewhere around 16 weeks of gestational age. And at this point, most people will say, we're going to forget about the airway and we're going to switch over into more of this type of a model where we start seeing development of the Asner units and of the lung. Now, one thing that people forget is there's a lot of things that are happening to the airway in the last half of gestation. Come to the BPD conference later today and we'll talk some more about that. But there's ongoing development of the airways that are going to occur from 16 weeks until term that are going to predispose these children to having airway problems. But when we think about the saccular phase, or when we think about the lung growth and the canalicular phase, we're starting to see kids that are being born in this area here, somewhere in the 22-week being what ACOG is recommending for aggressive resuscitation, or at least the offering of that. And I've even got some children in my clinic, they're in their 21-week gestation range. There are reports in Japan that we're going down to 20 in some cases. So it just keeps getting younger and younger and younger as our neonatology colleagues continue to push the limits of survivability. With this, we see a lot of problems as the airway progresses in the late generations of the airway, particularly in the small airways and then down into the Asner units. If we look at this under a micrograph, this would be a healthy lung up here. This is going to be a patient with BPD, and this is obviously a postmortem specimen for this kid. And as you zoom in on this, you get big holes that can fill up the airways. You get scarring and fibrosis. You have a reduction in the alveolar surface area. You have a reduction in the pulmonary capillary bed. And it's this that is leading to the problem with impaired gas exchange. And indeed, impaired gas exchange is how we've defined BPD really since it was first described. The first definitions came out in 1978, so almost 50 years ago. And the short version, it was a patient who was on 28 days of supplemental oxygen that was born preterm with characteristic changes in the chest X-ray. Now, they didn't really bother to define what those characteristics were, but that's what we used. That stuck around for about 20 years. And then in roughly 2000, there was a new definition that started to come out, which still relied on the supplemental oxygen use. And it then tried to stratify the severity of this. So patients that were less than 20, or that were on for 28 days and off by the time that they were term corrected or 36 weeks corrected were defined as mild. If you were on less than 30% oxygen, then you were defined as moderate. And if you were on more than 30% oxygen or positive pressure, whether invasively or non-invasively, you're defined as severe. I want to think about that for just a second. The severe category, I can have a patient that is on a liter of 31% oxygen, and I'm going to call that the same process as a patient that's trach and vented on peak pressures of 50, 100% of oxygen, 20 of nitric, triple pulmonary vasodilator therapy, and having code spells. This is not the same process, but we call it the same thing. So we tried to make it a little bit better. And these two came out in 2017 and 2018, I think it was, respectively, and try to get a little bit more granular in how are we going to break down the disease process of BPD. Doing more with different levels of flow rates, different levels of CPAP, non-invasive positive pressure that has bi-level support. And the one that seems to be taking favor in the last 5 years or so has been this definition that came from Eric Jensen. And it's looking at the support level at one time point, only at 36 weeks. And actually, if you were not on support, you would no longer be defined as BPD based upon this. So that old mild definition is gone. If you're on less than or equal to 2 liters, then you would be grade 1. If you're more than 2 liters, you're grade 2. And if you're invasively ventilated with a ET tube or a trach, you'd be defined as grade 3. Now, keep in mind, all of these are defining a disease process based upon your treatment outcome. And I would liken that to going to an orthopedic and saying, "Doc, my knee hurts. What are you taking for controlling your pain?" "Taking Motrin." Well, you can be like this kid here. I got a scrape on my knee. Or, "Doc, I got a knee pain." "Well, what are you taking?" "I'm taking fentanyl." "Okay, you're Peter Griffin that's over here writhing with a torn meniscus." You're defining a disease based upon its outcome. And this really doesn't tell us anything about the pathophysiology, or tells us very little about the pathophysiology of what's happening. So I want to jump back to this particular question. What is BPD? For residents in the audience, please, I implore you, get beyond the concept. It's just preemie lungs. There's a lot more happening to these kids. And as an example of this is a game that I like to play when people come and do clinic with me. But Erin's smiling. She's probably seen this slide before. Is what is BPD? These are 4 different CT scans from 4 different patients. All were born at 24 weeks. All are intubated at their 40 weeks corrected age. And if you look at these, it is not hard to understand that these are not the same kid. This is not the same process. You've got this patient that's got all kinds of scarring and fibrosis. You've got this patient who's got this gigantic emphysematous bulla over here. Turns out this is actually the lung that works in this patient. Also scarring and fibrosis that's happening over here. You've got this patient, you've got a gigantic pulmonary artery. The lungs, frankly, look pretty good. And you've got this patient. This is actually a normal left main bronchus over here. This is a trachea that is 2 centimeters. This baby who is 40 weeks corrected has a trachea that is bigger than mine. It is quite abnormal. This patient went on to get trach and vented, is now still on supplemental oxygen. This patient was trach and vented, is off of all support and going to school and doing great. This kid actually went home room air, and this kid did not survive NICU. So all have the same diagnosis, all have wildly different outcomes, all have wildly different disease phenotypes. And for us, one of the things that we're trying to do is we're trying to use some of our advanced imaging techniques that we have access to in Cincinnati using ultra short echo time MRI to be able to better define what it is that the disease process is changing with time and how things are going to progress and different processes that may be happening for the patients. With ultra-short echo time MRI, we're trying to be able to visualize the lungs without radiation, without sedation, and we can do this as many times as we want because there's minimal risk to the patient, and we're also able to do it right here in the NICU. Now, people will say you can't look at the lung using MRI. In fact, you can. Most of the time in MRI is, you'll hear it go in, it goes kind of ka-chunk, ka-chunk, ka-chunk. Well, this MRI, instead of chunking, it hums at you. It's capturing signal on the order of milliseconds rather than on the order of seconds. So you can get images like the one seen here. And if you look at that image as you get it at a normal time for acquiring the signal, you get something that looks like this. So some of our BPD kids, I'm just highlighting over here, and you could be forgiven for looking at these images and thinking that this actually is a CT of the chest rather than an MRI of the chest. So very nice images that we're being able to get for our patients. And we're fortunate, we're able to do it right here in the NICU. So initially we had an adult thigh scanner that we were using. Now that has since been upgraded to a much nicer thing that actually fits babies and is a little bit faster in terms of the signal acquisition. But being able to get these very high resolution chest MRIs that give us resolution down to about 0.7 millimeters, very similar to that with a CT. And again, all done without ionizing radiation, without sedation, and can be done with the bedside nurse in the NICU. And as we've been doing this, we're starting to try to understand different phenotypes with imaging as a biomarker about what BPD is. And for us, we've been dividing it really into, I'll go with kind of 3.5 categories. Parenchymal lung disease, which we are categorizing more into 2 different groups, alveolar simplification, and then scarring and pulmonary fibrosis. Pulmonary vascular disease, particularly pulmonary hypertension. Don't forget other things that can happen though, PDAs, pulmonary vein stenosis, and many others. And then also central airway disease, in particular tracheomalacia and subglottic stenosis. Now, lest you think that the only place that was doing that is Cincinnati, this is some work that came out of Children's Hospital of Philadelphia a few years ago, using a very similar categorization system, looking at parenchymal lung disease, central airway disease, and then also pulmonary hypertension. And one thing you'll notice with this, very frequently, there's a lot of everything. You don't typically just have one component, but understanding different components of disease can help us drive therapy for these kids. And then as we're trying to look at the use of the MRI that we've been doing, one, we're over, actually this is a little bit out of date, we're up to about 300 patients now, I think it is. And we're trying to categorize what is the nature of the parenchymal lung disease using a modified CT scoring system that we had developed about 10 years ago at this point. And also using things like lung density measures just to look at the parenchyma. And the first work that we had done with this was just trying to say, does this even make sense? And so here we're doing a scoring system. It's on a scale of about 14. Patients that were term, score 0. That's what they should. The more severe your lung disease gets, the more severe your parenchymal scoring gets. And you can look at different aspects of the lung parenchyma to try to understand what's happening for the lung. It's more than just being able to say, can we parse out disease, though? We're also able to parse out some of what's going to happen with outcomes for the patient. So one in particular is the risk of trach. Not terribly surprising, as the parenchymal lung score is going up, so too is your risk of trach. And in particular, if we have scores that are in this range up here in that 12 range, basically very severe parenchymal lung disease, almost everybody ends up with a trach, no matter how long we try to wait. And this is one thing we found to be quite helpful for showing parents. They can actually see it, and a picture's worth 1,000 words to a lot of the parents who are really having trouble digesting what's going on with their baby, and can help make the decision to be able to move forward rather than continuing to try and extubate a patient and watching the child fail. More recently, we've been looking at, rather than the scoring system, we've actually been trying to measure the density of the lung. So looking at areas that are very hypodense, very simplified, lacking lung tissue, versus areas that are hyperdense, that probably is a combination of scarring and fibrosis. Turns out this probably is going to be better able to discern outcomes for patients, but more of that's going to come with time. Now, why is it important to know whether you have lung disease, heart disease, airway disease, all the above? And a simple answer is, if I've just got subglottic stenosis, treatment with systemic steroids is probably not going to move me towards extubation. But if I've got significant parenchymal lung disease, this is one meta-analysis that came out looking at late courses of steroids, you can actually be able to move kids towards being able to extubate. And as we look at our own experience in Cincinnati for looking at patients who had severe parenchymal lung disease, somewhere in the nature of half of those patients who were treated with late courses of steroids, which we'll define as after 36 weeks, about half of them were able to extubate. Of that half, about half of those were able to stay extubated. So approximately 25% of our kids who were stuck often on very high vent support that were prepping to move towards trach were able to get extubated and were able to stay extubated. Now, we did see some challenges with that. One, they don't grow well while you do that. No surprise there. There's a lot of concern about what are the neurocognitive outcomes with that. So we've been looking at what are their GMA assessments going to be, and they're going to be following their neurodevelopment later into life. It doesn't look like these late courses of steroids are having the same impact as you see in the early courses of steroids. That said, don't use them unless you need to, but there is potential to be able to support your patient. Going to go back into the phenotyping again. We're going to get out of the lung parenchyma and we're going to move over into the airway for a little bit because that's the area that I love. If you can give me something to bronch, I'm going to be a happy guy, but they tell me I can't bronch all the babies in the NICU. Pam, I hope you can help me with that at some point. But looking at bronchoscopic findings in babies with BPD, very frequently these babies have abnormal airway findings, particularly airway edema. No surprise, there's a lot of neutrophilic inflammation. And then also dynamic disorders of the airway like tracheomalacia, bronchomalacia are extraordinarily common. Fixed obstruction of the airway from granulation tissue, subglottic stenosis, tracheal stenosis can also be seen, and also point out that somewhere around 30 to 40% of these babies that have a BAL, so you're sampling the alveolus rather than just the ET tube, they're going to have positive respiratory cultures, and you can probably improve their outcomes a bit by making those go away, but that's a little bit less clear. And thinking about what you might see on a bronchoscopic image of this, here's a bronch of a normal baby on the left and a bronch of a baby that with BPD, who was a ventilator-dependent kid. And you'll start seeing the trachealis flip up, and it's actually, the trachealis is actually touching the anterior cartilaginous rings. You can imagine when this child bears down that this child's going to have a lot of problems. And this is where you can see some of those death spells or the death poops that we see in the NICU. I think a lot of that comes from the airway really collapsing on itself and not being able to move air. Again, same video of a normal baby on the left and then a baby on the right. You can see this baby is making tons and tons of respiratory effort, but those vocal cords are just not going anywhere. They are completely fixed. And every time this baby would try to extubate, this baby would fail. And it would fail quickly. And she would have stridor and she was in distress. And you're going to see as we come back here in just a second, there's a big old scar band sitting right here with keeping those vocal cords tethered together. So even though the subglottis sizes normally, those vocal cords can't open because they're fixed in place. People tried to give this baby steroids. Guess what? It didn't work because the baby didn't have parenchymal lung injury, or not much. The baby had significant airway injury. And airway injury certainly has been associated with bad outcomes in this patient population. This was some work that we did about 10 years ago now, using the Children's Hospital Neonatal Consortium and about 1,000 babies with BPD who had tracheomalacia. And no surprise, if you have airway disease, it's with lung disease, it's worse than lung disease alone. These babies with tracheomalacia were more likely to end up with trachs. They were more likely to end up with G-tubes. They spent about 3 or 4 weeks longer in the hospital, and they ended up going home with a lot more respiratory support. Interestingly, they go home with a lot more inhaled steroids, and they go home with a lot more bronchodilators. And we'll kind of come back to that here in a little while. It's also not just in these consortium type databases, though. This is some of the work that we've been seeing in our own population. Again, going back to our MRI. By the way, thank you to Alistair Bates, because that's just cool. But if we see dynamic airway collapse and we go back to our parenchymal lung injury, so these patients here in green, these are patients that do not have any evidence of airway disease and their risk of trach. In yellow is looking at mild to moderate airway collapse and the risk of trach. And it's almost like you shift up the risk, which again, this makes sense. If you've got airway disease with lung disease, it's worse than lung disease alone. In our patients with very severe airway collapse, all of them ended up moving on to trachs. Again, small sample size on here, and at the about 300 kids that we're looking at this point, we continued to see this preserved. Now, very important though to realize that there's some things that we can do about this. And this is a study that came out of Arkansas maybe a year ago, looking at the use of bethanechol for babies with BPD who were stuck with trachs or were stuck with chronic respiratory support. And on the top, you're looking at babies that were treated with controls in their respiratory severity score. So in this case, higher numbers is worse respiratory outcomes. And then as you're seeing in the babies with the bethanechol group, over time, you're seeing their respiratory severity scores are getting improved. So they're weaning off of their medications. Some of them have been able to reduce their mean airway pressure, their FiO2. Now, is this a magic bullet? No, but in some of these patients where we're trying to be able to keep them alive, we're trying to buy everything we can be a useful thing to be able to do for the kids. And turns out it's generally very well tolerated in these patients. Going back to our general model idea for looking at babies in the NICU, we're going to switch over into the heart and just briefly put some time here. Again, we are fortunate with this technique with the MR that we have, that we're getting cardiac MRIs as we're getting the lung and as we're getting the airway, which gives us a pretty complete understanding of what's happening in the chest. And looking at a few things, we're looking at the aorta to pulmonary artery ratio, taking lessons from CT scans. We can look at what is the eccentricity of the ventricle or the right ventricle. And a patient here is normal. This patient really quite flattened. And this patient had problems with pulmonary hypertension. We also are looking at septal curvature. And if you get a septal that's kind of bowing in the wrong direction, then we're having evidence of pulmonary hypertension. We are getting insight into PDAs and BSDs and pulmonary vein stenosis as well. But I'm going to just focus on the pulmonary hypertension for right now, because PH, it's bad. Again, this is some work that came out of the Children's Hospital Neonatal Consortium, probably, 7 years ago now, and looking at the outcomes in the NICU for patients with pulmonary hypertension and BPD. PH was associated with longer stays, it's higher risks of trachs, it's higher risks of mortality. They tell me that dying in the NICU is usually not the goal, and the high mortality rates with PH is really something that people have seen for quite some time and has been preserved across multiple different sites. The problems with PH also extend beyond. They're more likely to end up going home with supplemental oxygen. They're more likely to come back into the hospital. They're more likely to end up in ICUs when they go home from the NICU. So trying to avoid PH is something I think is a very important thing to do for these patients, or when PH occurs, try to manage it. And so this is some studies that have come out looking at the use of pulmonary vasodilators for your patients with BPD and pulmonary hypertension. And for these patients, we can see a reduction in pulmonary arterial pressure. You can see reduction in their in BNP with evidence of right heart strain, and also improvement in their oxygenation following treatment with pulmonary vasodilators. Many of these kids are going to be on these medications once they get started for the first several months of life, even the first couple of years of life. And in particular, some of the severe kids may never be able to come off, although the general trend is patients are going to be able to come off with time. With that in mind, and thinking of kind of compartments of cardiopulmonary disease, in Cincinnati, we've started to try to develop a model where we've got people that are going to be able to try to manage the different components. So with our service, neonatology, of course, is driving the service. They're seeing these patients every single day, and there's an army of our neonatologists here. We have about 7 that are dedicated to our more severe kids, along with several dedicated APRNs, RTs, dietitians, pharmacists, etc. Lots of resources going into taking care of these babies from the NICU and seeing them every single day. The pulmonology we round with our NICU colleagues at least once a week on everybody, and then some of the more severe kids that we will see at least twice a week, and often more than that if they're particularly problematic. Similarly, we have an army of APRNs. We also have our program coordinator and then several of the RTs that we work with on that group. The cardiologists are reviewing all the echoes and all the cardiac MRIs for our patients and trying to help make sure that they don't have cardiac contributions to the patients. Sometimes it actually is the heart, even though they like to say it's not. And we're then using all of this clinical care and all this imaging technology to inform our research colleagues, where our nurses, our PhDs, folks that can try to help us understand what's happening for these patients, and allowing our research to inform our clinical care and our clinical care to inform our research. Just as a quick aside, don't forget the alphabet soup of BPD. It's not just the heart and the lungs, it's the brain, it's the eyes, it's the belly, it's infection problems, it's airway reactivity. They need to grow. And there's many other heart things that we really have not talked about, but there's tons of things that are happening for these patients. So it really does take a village of people to be able to take care of these patients during the NICU stay. And this is an older slide, though, looking at our inpatient team and folks that are truly dedicated to taking care of these population, particularly the most severe patients. Now, with that, what have we gotten from this? And this is something that I'm quite proud of, honestly, some of the work that we've done to improve the clinical outcomes for these kids. And I'll draw your attention over really to the left-hand side of this graph, looking at, in Cincinnati Children's, what was our mortality for our patients in the first year of life before we started our BPD program about 10 years ago. And it was about 10%. Which was pretty consistent with national averages for patients who had survived to meet a diagnosis of BPD. That has subsequently fallen. In this particular slide, it shows above 5%. It's closer to about 4% now. So we continue to make progress. in keeping these babies alive. And this is including patients with more extreme prematurity. They are actually sicker in terms of their BPD and parenchymal lung injuries, but we're having improved outcomes. And it's not that we're just traking everybody, because that's something that we want to be careful with. We want to make sure that we're not just creating more and more challenges. Our trach rates have actually been falling. They used to be closer to 30%, which admittedly was quite high. And now we're down to about 15% this slide. So there's 20, but it's about 15% that we've been at. So even with more survival, presumably of the sickest patients, more extreme prematurity, more severe lung disease, we're actually seeing a reduction in the amount of tracheostomies that we're providing for the patients. And I have to admit, our program coordinator is Laura Ballou. When she wanted to create this slide, I was very hesitant because I thought it was going to go the opposite direction, but turns out she was right, and I should usually listen to her. I think a lot of our outcome improvement has been related to this. So this is looking at our pulmonary hypertension prevalence at Cincinnati Children's Hospital. And in the early 2010s, we were at about 30%, which again, very consistent with national averages at the time. Since we started the BPD program, this has plummeted, and we are down at about 4%, 5% of our kids are having pulmonary hypertension. And given the very high correlation with survival and trachs, I think this is probably a major driver as to why we're seeing some of these improved outcomes. Now, I'm going to go back to our original question. What is BPD? Well, it's chronic lung disease of prematurity. It's chronic for a reason. It's chronic. It doesn't go away. And so we have to continue to follow these kids throughout their childhood and adolescence. So one thing that we've done in the last couple of years is we started to develop our multidisciplinary long-term clinic for being able to follow the toddlers for these patients with a combination of neonatology, pulmonology, our pulmonary hypertension group. There's nursing support, there's OT, there's PT, there's dietitians, there's social work. There's a whole slew of people that we're trying to use to be able to provide care for these patients when they leave the NICU. And for my purpose, we're doing this with a few things in mind. We're trying to avoid hospitalizations for these kids. That's a major source of stress for parents. As you look at this, it's almost like a PTSD type of a reaction for these parents. They've been in the hospital on average, 100, 120 days, and dealing with all the ups and downs of a sick, unstable baby in the NICU. And then they go back, they will have a very difficult time dealing with that. If they're on respiratory support, we want to try to be able to get them off of respiratory support. We want to do that as quickly and as safely as we can. And then also optimizing growth for my purposes, to try to improve lung function. Now, in the context of thinking about avoiding hospitalizations, another thing I would tell people to consider, BPD is a distinct entity from bronchiolitis. And I mean this in a couple of ways. One is, if you look at the bronchiolitic guidelines, a lot of the bronchiolitis guidelines actually specifically exclude patients who are born preterm and patients with BPD and in patients with chronic lung disease. The other is you're dealing with a chronic lung disease. And we think about exacerbations of cystic fibrosis, or the exacerbations of PCD, exacerbations of asthma. I try to encourage our trainees to think about exacerbations of BPD, often caused by viruses. And watching and doing nothing other than respiratory support is probably not appropriate for some of these kids. And so why would that be? Well, one, if you look at lung function testing, half of your patients are responsive to bronchodilators. It's actually probably about 2/3. As opposed to your general population, which is about 10%. You may have pulmonary hypertension that may flare in the setting of an illness, and maybe you have to go managing that. Systemic steroids, we're seeing that those actually do improve outcomes even in the patient that is not acutely ill, or really can improve respiratory status, I should say, in patients that are not acutely ill. Not entirely clear what it does when they're sick, but it's probably beneficial. More to come on that at some point. Do they need to have some diuresis in the setting of an acute illness? Chronically, probably not going to do a whole heck of a lot. In an acute setting, there may be some benefit to it. For patients that are having recurrent hospitalizations in particular, consider treatment with inhaled steroids or inhaled steroids and long-acting beta agonists. Another thing that happens frequently that we come into is that patients are often not on adequate baseline oxygenation, and you're running them right at the ragged edge of respiratory failure. And so if you give them an additional hit, they just simply can't tolerate it. And just looking at this, again, a little bit, some of the data that comes from this. This is looking at methacholine challenge data. Now, admittedly, these are not infants. These are kids that are a little bit older. But on the dark black here on the left side, you're looking at the methacholine response in healthy kids. About 50% in this study had a positive methacholine response at the highest doses. For isolated preterms without BPD, that was about 70%. For patients with BPD, independent of how severe their underlying lung disease is, that number approaches 90%. And I will tell you, this is all comers with BPD. So that includes that kid that was on 28 days of oxygen and weaned off by 36 weeks. You're not really looking at your trach and vent kids. You're not really looking at the kid that's on high flup. The sicker you are, the more likely you are to have a positive response. And with that, we also know that you can reverse a lot of this using things like albuterol. And this is some work that came out of Nationwide a few years back, just looking at infant PFTs in your patients with BPD. And I'll draw your attention to the right side here, is that patients who had abnormal lung function, particularly those with obstructive disease, often had a positive bronchodilator response. Now, if you took patients who had normal lung function or near normal lung function, they were less likely to improve. Now, it's hard for me to make your normal lung function more normal by giving you medication. But in aggregate, around 2/3 of all their patients had a bronchodilator response based on infant PFTs. 3/4 of the patients with obstructive disease have a positive bronchodilator response based on infant PFTs. Precisely 0 of these patients were wheezing at the time that they got their bronchodilators. Okay, so just because the patient doesn't wheeze doesn't mean that they can't have improvement in how their respiratory status is going to be. With that in mind, we've been starting to try to be pretty aggressive in looking at lung function and in bronchodilator response in our patients with BPD in the toddler period with impulse oscillometry. We don't have the ability to do standard infant PFTs. Once they get beyond about 6 years of age, we're using spirometry, more standard techniques, starting to do lung volumes and diffusion capacity when they get to be 8. That's about as young as you can get somebody to be able to do that. We're going to get into some more about some of the concerns for what's happening with the heart as these kids progress through childhood, but we're getting echoes around 10. Our cardiologists are very interested in doing cardiopulmonary exercise testing, again, around that same time. And then we're starting to more and more to consider, should we be doing more advanced imaging that's a bit more sensitive to understanding disease, either with hyperpolarized xenon MRI or with inspiratory expiratory CT for some of those who might not be able to do it. And with this, some of the work that we're finding, this is our first 100 kids that we did impulse oscillometry on when they came into our outpatient clinics. And this is generally a population of our kids because we're seeing just about everybody that's graduated from NICUs in Cincinnati. So there's not just kids that are sick enough to find their way to a pulmonary clinic. This is really reflecting more of a population. On the top, you're looking at resistance of the respiratory system. The R7 you can think of as the entire respiratory system. The 20 is going to be large airways, and then R7 minus 20, you take away the large airway from the total airway, you're left with the small airway. And we're looking at pre and post bronchodilator assessments. The overwhelming majority of these kids have an abnormal impulse oscillometry, and almost all of them normalize when you give them some albuterol when they are normal to begin with. On the bottom, we're looking at the kind of the stiffness of the lung rather than the stiffness of the airway. In particular, X7 as reactance is really what this is, but you can kind of think about it like compliance. And they have abnormally low compliance. And then when you give them bronchodilators, things tend to get better. Similar things with the resonance frequency in the area of reactance. And it's not just that their function is abnormal. It's actually, this is going to predict some of their outcomes. So our patients who had hospitalizations, they tended to have more stiff lungs and they tended to have more small airway disease based upon their X7 and their AX. And then the ones that did not, are then the ones who did not get admitted into the hospital. Again, this is no surprise. If you've got sick lungs and you get sick, you're likely to get sicker. But it's also important to realize there are things that we can do about this. And so for our patients that had a positive bronchodilator response, many of them we started treating with combination therapies with inhaled steroids and a long-acting beta agonist. And you can see preservation and normalization of that lung function, not just in that moment when they get their albuterol, but as we're following them forward into time. And it seems like that the LABA actually provides better support for these kids than does the ICS alone. Now, not just managing the airway reactivity, I also think it's very important for trying to keep these kids out of the hospital to make sure that we're oxygenating them well. And the American Thoracic Society came out a couple of years ago and said, please check your babies and make sure that you're oxygenating them well, certainly before you bring them off of oxygen. And I would encourage that it's actually probably a good idea before you send them home from oxygen, because oftentimes what we see and what are reported in the flow sheets in EPIC are not going to actually reflect the reality of what's happening for the patient. And it can have some important implications for our kids. So this is some work that our program manager actually did, and looking at how likely are kids to come back into the hospital based upon how they're oxygenating when they leave. And so for our kids on the left who are having high oxygenation when they're leaving, so most of their time is greater than 95%, they're spending some time in the low 90s, very little time in the 80s. About 5% of them came back within the first month. For the kids that are sort of in your they're spending more time at low baseline oxygen. They're spending about 90% of the time above 95. That number increased to about 10%. For our patients who spend less than 90% of their time with high SAT, SATs above 95%. And again, this is at hospital discharge. about 20% of them end up coming back into the hospital. And for our patients who we never assessed, again, about 10%. So our patients who were oxygenating better at the time that they were discharged from the hospital were actually significantly less likely to come back into the hospital. And not showing the data here today, but there was no increased risk of ROP. There was no increased risk of the need for medications for ROP. And there was no evidence that they were having worsening outcomes in terms of their neurodevelopmental capacity. If anything, it's probably a hair better, but we're going to get more detail on that as time goes on. When they do leave, we also try to be very direct about how we're going to wean oxygen for our patients in the outpatient setting. And one, we'll typically wean oxygen first because our parents tend to find that's the most difficult thing to be able to deal with. And the general concept is, you don't have to go through the entire flow sheet here, but if you're having high oxygenation with good growth, wean the baby. No real surprise there. If you're low oxygenation, don't wean the baby. And then before babies are going to completely come off of oxygen, we're doing some form of objective assessment, trying to look at what is their oxygenation really in particular at night when they're most likely to desat, and whether that's a sleep study or we typically are doing more oximetry studies because we would break our sleep lab if we tried to do sleep studies on all these babies. We do a lot of oxygenation studies with recorded home oximetry. And something I'm going to draw your attention to is what we're finding. 2/3 of parents that reported precisely zero evidence of hypoxia, it turns out their child ended up having clinical definition of non-apneic hypoxemia when they were being studied in sleep. Parental report is abysmally bad, unfortunately, and they have to sleep. They also want to get their kids off of oxygen. So there's reasons to do that. They just may not know. Your averaging time on your pulse ox at home is probably 20 seconds. Maybe it's 10, depends on how you set it. Whereas if you're looking at more of a breath by breath evaluation, kind of like what we would do in a NICU, you're going to be more likely to identify hypoxemia that the parents wouldn't be able to see. Once they're off of the oxygen, then we'll start trying to pull off other medications that may be available as well. But again, trying to get the thing that's most intrusive for the family off first. We also started working on a multi-site study using really transmittable oximetry data with the RAD97 device to see, can we improve this by having increased points of contact? And the short answer was, yeah, we can. On the green here, you're looking at, as we implemented this algorithm for weaning respiratory support, we've actually been able to get patients off of oxygen more rapidly. We were a little surprised by that. We thought it was going to take longer. But I think what was happening is we were weaning kids who were suitable for weaning, and we were holding kids more rapidly, and then we were holding kids that really were not ready to come off. They were staying on for longer periods of time. In the pink, as we started to use this more transmission to our desk at one of our nurse coordinators' office chairs, we were able to start weaning these kids even faster. So we were able to get down to about 4.5 months, 3.5 months of being home and coming off support, while concurrently reducing our rates of kids coming into the hospital. And this is one that I want to show you about that. And there's a couple of ways to look at this. And again, I'll draw your attention to the left side of this. The blue, different shades, is before we started our outpatient program. The green is after we started our outpatient program. And since we've done this work, we've seen about a 50% reduction in hospitalizations within the first month of discharge, within the first year of discharge, and then within the first 2 years of discharge. So even though we are weaning kids a little bit faster, we're getting kids to be able to stay at home more often, which is, to me, is a really big win for the family. And some work that has been recently submitted is just trying to look at this. These are our first roughly 25 kids that we were seeing in our combined clinic. The emissions that we were seeing that were being reduced really are going to be respiratory emissions. Total emissions was down from about 0.8 emissions per patient per year down to about 0.3. And almost all of this, not surprisingly, was done with respiratory illnesses, so that we were reducing the respiratory emissions for these patients. There ends up being some cost saving to the system as well, because being in the hospital really is quite expensive. I'm going to shift now from out of our toddler period and then start getting into childhood and adolescence. And in childhood and adolescence, a major goal is going to be to optimize lung function, to manage and to maintain it, and then to deal with any ongoing respiratory symptoms for these kids. Again, it's chronic lung disease for a reason. It's chronic. It's not going away. And this is a meta-analysis that came out a few years ago, looking at lung function for our patients with BPD when they get to be in their adolescent period. And not surprisingly, their lung function, it's low relative to term-borne controls. It's about 1 Z-score lower than what it ought to be. Concerningly, we're starting to see evidence that there is early onset decline in lung function. So this is data from Australia. looking at their cohort of patients with BPD, and they're looking at FEV1 Z-scores. The FEV1 Z-score ought to be absolutely flat throughout childhood and adolescence unless you've got a problem. And what they were seeing is Z-scores are beginning to decline somewhere early on in childhood for your patients with BPD. And a bit more concerning, we're seeing that in patients that are preterm without BPD. So there's a whole lot more patients to be able to deal with. A lot of it is going to be in the small airways. So this is the FEF 2575, and we tend to see more obstruction in the small airways and a more rapid rate of decline. So we started looking at that in Cincinnati as well. It's like, is this something that they're seeing or is this something that we're seeing? And so these are data from our center looking at about 1,000 patients that are born preterm with and without BPD. And just to give perspective, I put our CF population up here on the top. And what you'll see here is our patients that are born preterm, they have lower lung function on average at every age than does our CF patients. Our BPD patients are even worse than that. And we're seeing similar trajectories of decline for our patients with BPD. And this is before we have modulators for CF, which I suspect this will look very different in terms of our CF lung function as we move forward. And we have precisely 0 therapies that are designated for patients with BPD. What happens in the NICU course informs what's happening in the children as they move forward into time. So this is a graph looking at just the lung function based on the BPD severity using that Jensen definition that we were talking about. 0 in this case is just going to be premature no BPD. The lung function, it's not bad. It's around 85 to 90% predicted. It's not normal, but it's not bad. And I should say it's not normal as a population. The grade 1s, they tend to be a little bit lower. Grade 2 is lower still. Grade 3 is lower still. So the course that the babies had in the NICU is going to predict what's happening for these children long term. And we may be able to improve that with some other inhaled therapies, but there's certainly nothing that is dedicated for these kids. It also turns out that lower lung function likely correlates with some respiratory symptoms, which I'll show you here in just a minute. But it's not just expiratory flow, it's gas exchange problems as well. This is some data that was coming out of Europe, looking at diffusion capacity for these kids. They don't actually catch up. We used to say that they have catch-up lung growth and they're going to be normal by the time they're 3, 4, 5, 6 years old, something like that. Following these patients until they're in their 20s and 30s, as was done here, you can kind of see this nicely down in this area. Throughout time, your cases of BPD and preterm birth did not have normal diffusion capacity. A lot of this is going to be at the membrane level. They have problems getting gas from the alveolus into the blood cells probably because of membrane thickness. Not entirely clear why, but that seems to be a component of that. The alveolar space tends to be functioning reasonably well. The units that you have seem to go okay, but they're having trouble getting gas across the interstitium. Now, one of the challenges with a lot of these studies has been that perhaps this is all just patients that we're bringing in to be evaluated because they're having problems. So we've been working on a population-based cohort study of 400 and almost a little over 450 babies from around Cincinnati, from all of our NICUs, our main NICU at Base Hospital, and our satellite NICUs as well, trying to get a full picture of feeders and growers and in most of our severe kids, and trying to get more comprehensive evaluation for these patients with their heart and their lungs, using some of our advanced MRI techniques with the heart and also with xenon, pulmonary function testing, respiratory surveys. We're looking at body composition, which I'm not going to get in much to today. And then also what's happening with time. So we're assessing them at 6 and we're assessing them at 8. And we're primarily choosing those, 1, because it's how old the kids are now, but 2, because that's about the earliest assessment that we can get for these patients. So in this population cohort, these patients are not being evaluated in any meaningful fashion. We're just kind of pulling them in from their homes and from the street, other than they were seen in our NICUs when they were babies. And we also have our healthy controls. Healthy control, lung function, preterm no BPD, grade 1, grade 2, grade 3. And again, you can just see it. More severe neonatal course, more decline in lung function for their FVC. And then FEV1 showing a similar trend. One challenge we're having with the grade 3 children is a lot of these kids have some neurocognitive impairment and they're not really able to do pulmonary function testing to the best extent. So the N of acceptable spirometry here is a bit low, and probably why that looks a little funny there at the end. I'm hopeful that we'll get a more clear picture as we get more patients with grade 3. But even though they can't do spirometry, they can all answer respiratory questionnaires. And so we have been using the St. George Respiratory Questionnaire, which is really designed for COPD. But what we're seeing is that in symptom domains and total scores, the more severe your neonatal course was, the more symptoms you're having. A change in this scale of more than 4 points is something that is considered clinically relevant. Our controls basically score 0. They should. They're healthy kids. They shouldn't have breathing problems. As you get to your more severe kids, on average, they're scoring about 20. So again, each 4-point increase is a clinically relevant difference. We're seeing something similar in terms of their symptomatology, which is where a lot of this is based. The more severe your neonatal course, the more symptoms that you have. The thing that's very interesting to me, though, is the kids don't seem to care. They just keep right on trucking along. So how does it impact them? Yes, there's a trend towards more impact on the patients in terms of how their functional status is, but it's not really until you get into the grade 3s that we're seeing significant change in how it impacts the patient. And looking at the scale, we go from an impact of 0 for our patients that are controls to about 10. So it was from 0 to about 20 or 30. We go from about 0 to about 10 in terms of their impact. So these patients, even though they have tons of symptoms, they have tons of high total scoring, they just keep right on trucking. And their parents will tell you, they're doing fine. They don't seem to realize that this is not typical. And I think a lot of that probably is you had a baby who was sick in the NICU. And then now they're at home, they're going to school, they're running and getting into trouble on the playground and doing what they're supposed to do. So parents don't realize that their kids are not necessarily having normal functional status. It's not just the lungs, it's also the heart. So we're looking at the cardiopulmonary MRIs that we're getting, or the cardiac MRIs that we're getting on this patient population as well. And still working on the control data, but our patients with BPD, they tend to have abnormalities in their left ventricular systolic volume. You're seeing some dilation there. The cardiac index is similarly going to be elevated for BPD versus no BPD. It's almost certainly that the controls are going to be lower on both of these categories as well. We're seeing evidence of pulmonary hypertension by age 6 in these patients, and this is all comers. This is a population cohort. About a quarter of them are showing evidence of right heart strain by the time they're 6 years of age. So this particular slide gets me very concerned about what's going to happen for the hearts of these kids, especially as we continue to push the limit of viability. Go back to our question, what is BPD? Well, it's progressive obstructive disease with alveolar microstructural changes. And this is some work that we're trying to do using some more advanced MRI techniques with hyperpolarized xenon gas. Hyperpolarized xenon gas allows us to look at regional ventilation and regional changes using the xenon and where it's going to go. And a few things we can look at: ventilation defects. So you can kind of see there's little holes that are in this lung here where gas is not going. We can look at alveolar size, how far it takes to get from one end of an external unit to another, and then how well gas is being able to get across the membrane and then also into the blood. And briefly, you can just kind of see some of these nice MRIs and just looking for areas that are going to be abnormal. On this one, it's kind of spinning, and I should thank Jason Woods for providing a few of these slides. There's areas that are just completely not functional using the xenon. And we can try to assess this and also potentially assess response to therapies. We're also able to look at where is the gas going in the alveolar unit. So this is what should be happening. You should have very small alveolar units. This is actually looking at an adult with COPD, and you can have just more time for how long it takes for that gas to be able to get across the alveolar space. And you can identify alveolar simplification with this. Now, I admit, when my imaging colleagues told me this, I thought they were out of their mind. I thought there's no way this is true. But then they actually took the micrographs from mice and also from some larger animal models, and plotted that against their measure for the apparent diffusion coefficient, looking at alveolar size. And it's really pretty hard to argue with that. So they're actually measuring that quite nicely. Another thing that we can take advantage of with the xenon, you can have the xenon get into the alveolar unit, and then you can actually watch as the xenon is going to diffuse across the alveolar space into the interstitium and then into the blood. And these are signatures that we can pick up using xenon with NMR techniques. You can look at where the gas is in the alveolus. You can look at where it's stuck, where it's going to be bound in the interstitial space with different peaks, and then also where it's going from the blood. So you can get a very complete picture of where gas exchange is or is not occurring using this. And as it turns out, even in our young kids, they're actually able to really do this pretty well. We actually had higher success rates with using the xenon MRI, verging about 75%, versus our ability to do adequate spirometry, which was about 40%. The only ones that were struggling were the youngest kids. The older kids tend to really do pretty well. And if patients have done more than one attempt at this, they tend to do really quite a good job. And as we're looking at what's happening for our patients across the lifespan, we're seeing with ventilation defects, and you can just think of where gas can't go. They're having more ventilation defects as they move forward into time. And some patients have really pretty profound abnormalities in ventilation defects. On this scale, normal should be about 2%, 3%. So patients like this that are having 20%, 35%, this is really quite abnormal. Looking at the alveolar size, there seems to be two different things that we're seeing here. We have a group of patients that tend to be very normal and resemble that of a typical healthy lung. and then patients that tend to be wildly abnormal. And there doesn't seem to be a lot in between. Don't really understand why this is occurring yet. This seems to be fairly stagnant. They don't seem to have worsening alveolar simplification throughout life. But some kids are quite simplified, some are not. Don't really understand that just yet. Looking at what's happening with their gas exchange with this technique, I also think this is kind of fun because you cannot look at gas exchange effectively until kids are around between 8 and 10 years of age. We're doing this in children as young as 6 at this point. They seem to get a lot of gas that gets stuck in the interstitium. That's this membrane uptake, and they tend to have problems with being able to get gas into the red blood cells. Again, no surprise, but this is potential setup for two things. One is going to be baseline hypoxemia, and then 2 is development of pulmonary hypertension later into life. Now, we can also do this in the NICU. So some of our PhDs are actually now not PhDs anymore. They're postdocs, but they're using the xenon in the NICU itself, and you can see areas like this in one of our babies where you just have this very large area of focal deficit for being able to get gas into this. Going back to our question, what is BPD? Well, moving forward into time, it's a risk factor for COPD, heart failure, and preterm death. And for those who are in the adult world, you may be used to seeing this, but this is just looking at a Fletcher curve of what is expected to happen with lung function throughout time. Our patients with BPD, they really don't seem to achieve normal baseline maximum lung function. They're starting to decline early in life, and it's unclear whether they're having a more rapid rate of decline of lung function or if they're going to have one that's going to mirror a more typical rate of decline in lung function. That's going to be a story that's going to be written. But as we look at adults with BPD, so these are patients that are in their 20s and 30s, their lung function similarly is low. Another thing that shows up, which I thought this was kind of interesting, is if you're small for gestational age in the NICU, that actually is going to inform your lung function when you're 30. Being small for gestational age knocks off about 10% of your lung function when you get to be in your 20s and 30s. So I thought that was quite impressive. As we saw in the kids, many of these patients have positive methacholine challenges, or they have lung function that's too low to be able to do methacholine challenges. They're sedentary. They're not very active. They choose jobs where they don't tend to have to be able to move around as much. They don't have as much energy expenditure. They're taking less steps in general as they move forward in time in their lives. And they've kind of modified their lifestyles in order to not have to be able to do quite as much activity as, say, a term-born peer that's in their 20s and 30s. It's not just the lungs, it's also the heart. So Karagas did this study a few years ago. These are asymptomatic patients that are in their 20s that were born preterm. Most of them are not patients with BPD, they're just less than 32 weeks. And she did cardiac caths on these patients. Fully half of them, by the time they're in their 3rd decade of life, meet criteria for having pulmonary hypertension, and they have increased pulmonary vascular resistance. This, I think, is particularly scary because, again, these patients don't know that this is not normal and they're at risk. And in particular, they can be at risk for heart failure. So this is some work that came out of, I think it was Sweden that was looking at this, looking at the risk of congestive heart failure for patients with BPD. And the more preterm you were, the more likely you are to have problems with going into heart failure. In particular, that risk seems to really peak when you start getting into your 30s. The less preterm you are, the less risk you have. So again, what is BPD? Well, it's progressive cardiopulmonary decline. And unfortunately, we don't have any defined treatment strategies for this at this point. But I want to leave a little bit of hope. So this is lung function for some of our patients. Baseline lung function with lung function down in the 70s, even in some cases down in the 50s. We give them ICS-LABA. We can bump their lung function by about 10%. Still didn't get into a normal range. We give them a long-acting muscarinic antagonist. We can get another 10% of their lung function. And both of them tend to be pretty preserved for most of our patients. So combined, if a patient has significant obstruction, we've been able to improve their lung function by up to about 20%. Looking at some of our xenon work. So this is ventilation areas. So you see these areas in yellow that are not functional lung, and put these patients on ICS-LABA, you can notice that some of those areas are going away. So you can actually change the lung microstructure for these patients. You can change it in terms of their alveolar size. This I was particularly surprised by. This patient had a lot of evidence of emphysema with very large alveolar size. We put them on ICS-LABA, and you see that that goes away. I'll be very curious to see moving forward if this is something that we're going to see or if this is an N of 1 and we just happen to get lucky in this patient. So why bother? We've got all these potential problems. There are some hope for it, but there's nothing specific. And I remind folks of a kid like this. So this is a friend of mine. This is Waylon. And Waylon was a 25-weeker. He had CMV. and he was just sick as he could possibly be. After a couple of weeks, you see he's super edematous here. He had sepsis. He's on triple pulmonary vasodilators at this point. He's on 100% oxygen. He's on 20 of nitric. He is just sick as he can possibly be. Ends up going on for getting trach invented. He ended up having symbiotic stenosis, bad tracheomalacia as well. Well, this is him when he graduates the NICU. So this is on the way out to our trach invent unit. And then this is him going home from the trach invent unit. He's got his big old supplies of all of his hospital ICU type stuff here. He particularly enjoys chewing on the corrugated tubing. He chewed through it a couple of times, but that's called a leak in the circuit, and that created some problems for us. But he kept growing, and this is right after he got decannulated when he was about 3.5, 4 years old at this point, and on his way to go into Disney World. Him there shortly thereafter. Keep been following him. So this is first day of school here. He's actually here reading to his class. And I think he's first grade here. I can't remember for sure. And then the most recent picture that I have of him from this fall, and he's now about 8.5 years old. And he's got some challenges, but generally he's doing quite well. So even though there's challenges and there's problems, without people that were taking care of a baby like this, he would have died. And this is a kid that's now going to school. He's getting in trouble on the playground. He's doing things that a little boy is supposed to do. So this is a huge win. To conclude here, so what is BPD? Well, I think it's a combination of interaction with the alveolar simplification, pulmonary fibrosis, small and large airway disease, pulmonary vascular disease, and then other cardiac disease. There's lots of components. I don't think it's a single diagnosis. I think there are many things that are happening for these patients. We're defining this by the degree of respiratory support, and I think we need to get beyond that. Beyond this is just preemie lungs, because there's individual components that we can target and try to be able to support. Imaging biomarkers may have a potential to redefine the disease. Don't forget, this doesn't stop when they leave the NICU. This is chronic for a reason. It doesn't go away. And we desperately need strategies to be able to help these kids and to try to be able to preserve heart and lung function as they move forward into time. And with that, I'm going to stop and say thank you all for your time and for your attention. For many of the collaborators, funding support from both the institution and from the NIH that's allowing us to do a lot of this work. And again, thank you all for inviting me to come down to Cincinnati, or come down to Phoenix. Thank you.
You did it. Okay, very good. Got one question here from the Zoom Q&A chat. How much oxygen do you send the babies home on? Question mark. How do you balance the need for good oxygenation with the risk of oxygen toxicity when kept at high levels, like roughly greater than 60% for a prolonged period?
So the liter flow that we typically will use is we try not to send patients home with more than about half a liter at a time. The reason that we've chosen half a liter is pretty much all of our kids that go home on 3/4 or more have bounced back into the hospital. And I think that probably just reflects, if you're needing that much to maintain adequate oxygenation, it reflects a degree of the stability of the patient. Not that you can't do that, but that's just the strategy that we've followed into. The oxygen toxicity question, I think, is an important one. And what I'll point out is I don't want patients that are having oxygenation 100% of the time, all of the time. So if we're finding that they are having high sats the majority of the time, that's actually our trigger to wean. So we're trying to keep them with oxygenation in the 96 range, more or less, so that you're not actually going to get as much oxygen toxicity from that. Now, the problem with that is some people will just leave kids parked. But again, we want to assess this regularly. If you're high satting, you should be weaning. But if you're low setting, we should not be weaning, or we should be increasing. So we are trying to balance that out. But it's a difficult thing to balance, because it's a tight window that we're trying to follow for these kids.
Okay, thanks for one question from in here, and then
Major benefits of the treatment with the ICS LAVA, is that only within the first year of life, or have you studied it?
Sure. So the benefits with ICS LAVA, and I also include LAMA in that particular description as well. Very little data in the first year of life. There is some evidence using impulse oscillometry and respiratory system compliance and resistance that you can improve that in the neonatal period, but there's not much there. Where I think we're seeing it is going to be more for our kids that are bouncing back in the hospital with every single viral illness that they're getting. And then certainly by the time they're getting to where they can actually do lung function testing, we can certainly see the improvement in their lung function. Incidentally, I didn't show it. You see improvement in the respiratory systems, the respiratory symptoms as well. So by 3 or 4 years old, there's actually measurable and detectable both clinical testing evaluation and then also patient-focused evaluation that you can see improvement with it.
I think it's time to let the residents go back. We've got one more very practical one in the Q&A here. He says, when you look at the histogram What numbers make you adjust FiO2? How much time below 90% makes you worry?
So the best data that we have on this is work that Larry Ryan was doing out of UMass. If you're spending more than about 5% of time below 93%, then you're associated with poor growth, increased hospitalizations, and then potentially you're going to have more cardiac difficulties with that. So if you're spending more than that, and this isn't a term corrected baby, by the way, not a baby that is still 26 weeks, different ballpark at that point. But more than 5% of time below 93, I would tell you that is the time that you probably want to increase the liter of flow, because you're running right at the ragged edge of respiratory success, especially for the baby that's at home.